Thank you, Dr. Ahmed, for the introduction. Again, thanks the organizers for the invitation. By now, after lunch and the last talk in the session, your melatonin level must be like very high. Anyway, to compensate, inshallah, it will be shorter than 25 minutes. So what we will try to cover in this talk about those four questions. What are the updates in the classification, the WHO classification of CML, and the view on the therapeutic targets? The second is the value of low-dose dasatinib in the newly diagnosed CML. The third is asciminib in newly diagnosed CML. And the last talk is, sorry, the last question is the value of the combination therapy. So we start with the WHO classification. So if you compare, if you look at the WHO classification in 2016, you compare it to the 22, the difference when it comes to CML is the disappearance of the accelerated phase. In 2016, we called CML accelerated phase if there was persistent splenomegaly, leukocytosis, thrombocytosis, and responsive to therapy. Persistent thrombocytopenia not related to therapy, basophils more than 20%, blasts more than 10%, and additional clonal abnormalities either at diagnosis or on therapy in the PH clone. Those were the definition of the accelerated phase. Now the accelerated phase now disappeared from the current WHO classification, and all of these factors plus additional factors came into the risk classification. So now those are high risk features in CML. So that's one change. When you look at the therapeutic targets, the therapeutic targets stayed the same. So to start therapy, the early risk stratification, the 3 months, 10% at 3 months, 1% and at 6 months, and 0.1% 3-log reduction, what we call MMR, at 12 months, stayed the same. There is no change. Also, the failure definition did not change, which is about one step higher. So like when it comes to 10% instead of 3 months, now it is at 6 months. And that applies to 12 months and at any time. So these did not change. The next is the value of the responses. So we know some responses are associated, these are molecular lab responses. They're associated with clinically important outcomes. And the first outcome that we know is important is the CCYR, what was called as the safe haven of CML. Once you achieve into you go into CCYR, your risk of progression is very low. So again, the view is the same, that CCYR at one year correlates with the better overall survival. Also, when you look at the MMR, the 3-log reduction, also the MMR correlates with better progression-free survival and also better overall survival. Also, when you look at the deep molecular responses, these deep molecular responses, the value of these responses are more to do with attempting the TFR. So these views on these targets stayed the same. So the only change is the disappearance of the accelerated phase. Now, the second question is in the therapy of CML is the use of low-dose dasatinib. Many of us kind of used low-dose dasatinib, like 50 milligram, in patients who could not tolerate 100 milligram. This study examines the value of that approach. And the rationale for that study is trying to decrease the toxicity of patients with CML. So what they did for newly diagnosed CML, there were 83 patients who were enrolled into that study, and they were started with 50 milligram. In patients who had suboptimal response in the study, they were increased to 100 milligram daily, and those were based on the ELN guideline. Those who had significant toxicity, they were decreased to 20 milligram daily. So there was dose escalation and dose reduction based on efficacy and toxicity. Now the endpoints are, you have the lab endpoints, the CCYR, CMR, MMR, and MR, deep responses, MMR 4.5, and the clinically important endpoints, the failure-free survival, the overall survival, and the other survival endpoints. Results. So if you look at the baseline characteristics, the median age was 47, but it included patients from 20 years of age to 84 years of age. The other thing to highlight in the baseline characteristics is the so-called risk category. There were like 64% of patients were low risk category. However, the 30% were intermediate and 6% were high. Even those with intermediate and high risk so-called category were enrolled into this study. Results. So the study was, the results were presented earlier, and that's the long-term follow-up at 16 months. And if you focus on the box here, the CCYR at 60 months, almost 100%, 98% achieved CCYR. That's safe haven. The MMR, again, very high, 95%. The deep responses between 70 and 83%. The complete molecular response was 70%. Again, very good for either the safe haven, decreasing the risk of projection, or even if you plan a TFR later on for that patient. So even when you look at the overall survival, the other clinically important endpoints, they were also very good. But these tend to be well in patients with CML. Now, what happened when you look at the toxicity was also probably lower than what is reported in the 100 milligram studies. If you look at the high grade toxicities, most of those toxicities were between 5, 7, and 1 and 2%, so they were generally low. And when you look at any grade toxicity, they were reasonably lower than what was reported, but not that bad. Specifically, when you look at the pleural effusion and grade 3 to 4 toxicity, only 2% of patients had grade 3 to 4 pleural effusion. So overall toxicity may be better than what was reported in the 100 milligram daily. Now, what happened to those patients? 9 out of 81, you had to increase to 100 milligram. And most of, so you had to increase to 9 because of these indications. Now, 20 out of 81, you could decrease it to 20 milligram once daily, and this is mostly because of the adverse event. When you look at the change to TKI, 10 out of 81 had to be changed because between adverse event, suboptimal response, and physician discretion. Also, for the treatment-free remission, there were 8 who attempted TFR, and only 1 of them lost the MMR. So all important goals of therapy may be achieved with that approach. So that's the low-dose dasatinib. The next question is the use of asciminib, the new TKI, in the management of patients with CML frontline, upfront therapy. So this is a phase 2 study that addressed that question. They included patients with newly diagnosed CML and gave them 40 milligram BID of asciminib. And then they continued. Now, if they had suboptimal responses, again, based on the ELN, the early response targets, they may be increased to 80 milligram BID, so almost doubling the dose. And if they fail, they could be changed to ninoltinib, dasatinib, or imatinib. So kind of you go asciminib and I don't have a response, you go to imatinib. But that's the protocol. You look at the baseline characteristics, almost like 56% 56 or 57 years was the median age, again included a good range of age. When you look at the ELTS score, again similar to the so-called score in the previous study, almost 67% were low, but then they were like 30% and 5% intermediate and high risk. So there's a good proportion of patients that are not low risk category. Let's look at the results. The early molecular response, which was the primary endpoint, 93%. So again, very good response, and this is early molecular response. When you look at the MMR, almost 50%, and the MR 4.5, 14%. So impressive responses. And then when you look at, that was at 3 months. When you look at 12 months, again, the responses were, the MMR was here improved to almost 80%. You look at the toxicity were not as we initially thought of asciminib. So 11% thrombocytopenia, hematological toxicity, and when you look at the, this is 11%, so almost 100 patients, and 5% grade 3 to 4. When you look at the lipase elevation, and I think one of the patients or more had clinically acute pancreatitis in that study, not much, but still, 16% lipase elevation and 6% grade 3 to 4. So, and fatigue lethargy 18%. And again, the people who stopped it because of lipase, amylase, and pancreatitis. So it's important to look at this category when you try to administer asciminib to those patients. So when you, I know from they have a phase 3 trial now comparing asciminib versus the other standard, versus actually nilotinib, again, two Novartis drugs. And what we hear that the study met its primary endpoint, and maybe now asciminib is getting into the approval in the first line therapy, but it's yet to be confirmed. The last question is the combination therapy. So this study looked at the value of combination therapy, but in patients who like in CML who did not achieve deep molecular response at 1 year. And this is the design of the study. Those patients who at least 1 year of the first line imatinib had a BCR able on international scale between 0.01 to 1%. And they had four or five, actually four, that imatinib, it was later stopped, between asciminib 40 milligram combined to imatinib, so they will add asciminib 40 milligram, they will add here in the second group 60 milligram of asciminib to imatinib, switch to linotinib, or increase the dose of 80 milligram asciminib. The baseline characteristics were also morely balanced, but there were significant differences in some of the areas. So when you look at, let's say, the median age, 48 years for asciminib 40 milligram with imatinib, which is higher than the rest, and the median prior duration of imatinib was also slightly different between the groups. And those who had MR2 and MMR were also different between the groups. It's a small study, so you expect some differences in the baseline characteristics. Responses. So the primary endpoint 4.5 at 48 weeks, but here this is 24 weeks, and the other one is 48 weeks. 14% for adding asciminib 40 milligram, the 19%. And then when you, for the, again, adding higher dose of asciminib, 60 milligram, and when you look at the 48, this has slightly increased from 14 to 19 and from 20 to 28%. Compared to the other, this has kind of stopped, so about 10% for those who use switch to linotinib, and 5% at 4. So it looks like if you add combination with either 40 milligram and or 60 milligram, you get numerically better responses than if you switch to nilotinib. So when you look at the median, also the median was much faster for patients who had combination therapy. And the rationale for combination therapy here, both the imatinib and the asciminib works on two different sites of the BCR-ABL. So this is why you are able to get into your primary endpoint with much faster median times. Toxicity. When you look at these are high toxicities, but it's similar between the groups, whether you would start 40 milligram, 60 milligram, or you switch to nilotinib, the toxicities were the same. You look at the serious adverse events and adverse events leading to discontinuation or interruptions, again, they are similar between the different approaches. So whatever approach you choose in this group, you get similar adverse events. When you look at the patients who had at least 15% adverse events, you see that this is where maybe that additional combination increases the adverse event. The nausea, the diarrhea, the myalgia, and the pruritus, but mostly the GI side effects. So, good, I finished now in almost 17 minutes. So what we covered in the last 20 minutes or so is to talk about updates on the classification of CML between 2016 and 2022, the approach of using low-dose dasatinib in newly diagnosed CML, asciminib in newly diagnosed CML, and we look for the approval in the primary, in the first-line therapy, and the value of the combination therapy. And with this, thank you for listening.